Thank you and good evening everybody. It's a real pleasure to be here and thank you all for coming out on this beautiful evening. I don't know how any of you ever spend any time indoors in such a beautiful city, so thank you very much. Okay, acknowledgements before I start. Many thanks to Alzheimer's Australia for inviting me here this week. I was very interested in the work that that Alzheimer's Australia WA are doing around looking at particularly community-based services and how we get those right for people with dementia. Tonight I'm primarily going to be talking about changing culture in care homes, but I think many of the issues are the same wherever we're providing services for people living with dementia. So I hope whatever sector you work in, that there'll be something from this talk that you can take away. And thanks also to the Alzheimer's Society in England, the Dementia Action Alliance, and particularly the Lady Forrester Care Home, because I'm going to be showing some of their pictures later on. And also to the Association for Dementia Studies team, my lovely team of 30 people working at University of Worcester. It is 2 syllables, Worcester. And, you know, I learn such a lot from other people that I work with that I know I'm in danger of nicking other people's ideas sometimes. So I make no apologies for including their ideas in this talk tonight. What I'm hoping to cover is to tell you a bit of, give you a bit of background of my department. I'm then going to work through understanding person-centred dementia care. I'm not going to spend ages on that because my guess is for most people in the audience that is familiar territory, but I just want to touch some basic tenets. And then to think about culture change and building cultures of care that are supportive of person-centredness. And I want to share 2 research studies with you that we've just completed. One is an in-depth study of looking at care home culture from the perspective of people with advanced dementia, and to really try and get underneath this term that we bandy about a lot around culture of care and say, well, actually, what is really important for people with more advanced dementia in care homes? So the bulk of my talk is going to be about that. I then want to, if we've time, to talk about a specific project, another research project that we've just done to look at decreasing antipsychotic medication in care homes as a way of improving the quality of experience for people. And then a couple of thoughts on the future. So the Association for Dementia Studies, Worcester University. Worcester is the little red dot. The upside down pink triangle is London, so you can see whereabouts we are. We're an academic research centre. We provide research, education and scholarship to deliver evidence-based practical ways of working with people living with dementia and their families that enable them to live well. So within that broad envelope of work, we cover a lot of different things. Anyone been to Worcester? It's ever so nice. That's the view from my bedroom window. Those are the Malvern Hills in Worcestershire. We tend to think it's a very rural county. For you, it's a bit like the size of Kings Park. You know, it's not rural as you know it, but in terms of rurality in the English sense, it's pretty rural. We're near to the Cotswolds. We've got some lovely, really cute black and white houses, if you're into that sort of thing. And over to Wales, we've got some great castles. So it's cheaper and less touristy than the Cotswolds, and I recommend it to you. 2.5 hours on what is called the Cathedral Express from Paddington Station, because it passes through Oxford and Worcestershire and Herefordshire. the cathedral bit is true, the express bit isn't true, it stops everywhere, but you know, if you're a tourist, it's quite a nice train to be on. So do come and see us in Worcester. That's my team. Many of us have had previous careers working in practice, either in care homes or social care or healthcare. Some of us have come up through more traditional PhD type routes, but many of us, all of us, are passionate about trying to make the place a better services better for people with dementia. Many of us have family experience of dementia, as I'm sure many of you do. And I just would say also tonight, you know, I was very happy to be called a world expert, but, you know, I'm here with humility and solidarity because I think the work that we're doing to try and improve the quality of care for people with dementia, it's tough work. I don't have a big bag of answers to give you. I don't have a takeaway. I have some things that we've been thinking about that I hope will help you think more about your practice. But, you know, if we work together on issues in our different countries and learn from each other, we've got more of a chance of really making a difference. The other feature of our work at the Association for Dementia Studies is that people living with dementia and their families inform our work at all stages. So this is our link group. These are people with dementia and their family supporters. They work as tutors, as paid tutors on all of our education programmes, and within our research projects give us the perspective of people living with dementia. So we try very hard to keep it real in terms of what we do. Okay. Now I'm going to put up a few numbers. Primarily these are UK numbers, but they're very similar numbers that you will have in Western Australia. And I quite like this graphical one that comes from our Alzheimer Society in the UK. So here we have our 2012 figures of the numbers of people living with dementia in the UK in 2012. That's what it will rise to in 2021. So we'll be at 1 million people living with dementia by 2021. But look what happens by 2051. And for those of you in the room, if you can calculate the figures of when you're going to be hitting the age of living with dementia, you know, I think that graphical picture shows us why this is of such importance for us to get right. When I first started working in healthcare 30 years ago now, you know, it was quite rare to see somebody with dementia in a care home. We'd call a psychiatrist, you know, and now that is our core business. And many of us feel ill-prepared to really help people, particularly people who are experiencing a lot of emotional turmoil and distress. And care homes were never set up for people with dementia. You know, that wasn't their function. And yet we've continued to have this as our main model now of long-term care. So I think, you know, it's no wonder, I think, that we feel challenged sometimes in our care provision. I think big numbers are really important, and really important to think about why, as a society, we might need to think about improving the quality of care. But sometimes also, I think, bringing your numbers down to a more manageable size. And I don't know whether you have equivalent numbers for Perth, for example, for Western Australia. But I often think, you know, that the more manageable you can make these numbers and make them local, it helps you really then to think about what the challenges are that your local communities are facing and your care homes. So this is Worcestershire, that's got a total population of about 580,000. And interestingly, looking along the age breakdowns, you know, our numbers of people under the age of 65 who will have dementia remain fairly stable, but there's still 200 of them. So that's the number of people in this room, you know, in our county, which is a tiny little county, really. And the ripple effects that we know for people who are living with dementia at a younger age are often much bigger and wider than if you're getting dementia at an older age. I had a very interesting statistic the other day, which I haven't verified, so don't quote me, but it was from a director of nursing in an acute hospital trust in Oxford that we're doing some work with. And she said we used to say, people with dementia are in every unit in a hospital, apart from maternity, and then we'd all have a giggle at that. But what she said was, if you look at the age breakdowns now, there will be 1,000 women per year in the UK who are giving birth who have young onset dementia. So if we think about having our babies later, so you do the maths. I mean, 1,000 isn't very many when you look across the whole country, but that's 1,000 people's lives, isn't it? So there are specific challenges that people face at younger ages, and we need to get better at working with people at a younger age. But if you look at where the real big increase comes, in our county, which is, fairly standard, reasonably affluent, not too rich but not too poor, but we have an ageing population, as does a lot of different parts of the world. It's our 85 pluses where we're going to be seeing the real increase in people living with dementia. So, almost a tripling between 2006 and 2026. And when we're thinking about dementia in the 85 plus age group, we know that dementia doesn't travel alone. Those people will have usually around 6 other long-term conditions that they're coping with. So arthritis, macular degeneration, frailty, So, and they're the people who end up in care homes. So I think if we're thinking about culture of care, that's one of the reasons why we really need to think about getting our care homes better than they currently are, even in Perth. Okay, so I'm going to do a quick what is dementia. I'm sure everybody in the room knows what it is, but it occurs as a result of progressive damage to the brain caused by underlying disease processes. Common causes: Alzheimer's disease, vascular dementia, dementia with Lewy bodies, frontotemporal dementias. But there are around 200 types of dementia. Some of them are very rare, some of them are very difficult to diagnose. And the type of dementia will mean that people have a different profile of disabilities. Dementias usually affect many parts of the brain's cortex, the thinking bit, over time. And that's the other issue around dementia, is that we can be supporting people for 10 to 20 years with the dementia. And the syndrome includes memory problems, reasoning, communication problems, and that gradual decline to carry out everyday activities. So that's our overview of what dementia is, which again, I could do a lecture on each part of those, but I won't, because I'm taking that as read for this audience. Okay, so we know, but being very clear that what we're dealing with is progressive neurological disorders. And if we really want to support people, we need to understand what behaviours people have because of that neurological damage and provide good support to them. And one of the strongest things that I think when we think about that symptom and we think about the biggest group of people who we're seeing, particularly in that older age group, is people with Alzheimer's type dementia. And we know by and large that it's a sort of first out, last in. First in, last out, rather. So that as the disease progresses, the things that get lost early on are memories and things that have happened since the dementia came on. And then what goes is the ability to remember what happened just immediately before the dementia set in. But those things that were there in your middle years, in your teens and 20s, are very well preserved, very often. And the things that were there from our childhood, our ways of relating to the world, are very strongly there. It might not be always, we might not always have the ability to talk about them within our dementia, but those things that are longest there tend to stay the longest. And many of our therapies and many of our ways of being within care homes or within community settings need to be recognising that and working with that strength, because there is a huge strength in having those well-formed, well-held memories and experiences. And we know in dementia that emotional reactions are as strong as ever. Dementia affects your thinking bits of your brain, it doesn't affect your feeling bits of your brain. And I think that's been a real shift in our understanding of dementia, certainly throughout my career. So those emotional reactions are as strong as ever. And because of the damage that's occurring, those past events and memories feel much more present than recent ones. But present events will trigger past memories. And what is happening in the present moment, therefore, has a significant impact on how the person feels. And I'm interested in, the posters that Alzheimer's Western Australia have put out, which talk about that. You know, the memory of what you've said might not be there, but the feeling is very strong. So if you're in a care home and you're feeling lost and abandoned, what it will trigger off in you is other times in your life when you felt lost and abandoned. You know? So the memories, and if there are strong trauma memories, those will come to the fore very quickly. And then if we are meeting that person with not nurturing care, if we tell somebody off, you know, actually what that person then remembers is the time when they were told off, when they felt lost and abandoned. So we compound it. It gets compounded much more in dementia than it would if somebody had robust cognitive ability. So when we talk about person-centred care, this isn't just about being fluffy and nice and kind. It's actually, that's the treatment for the disability. It's about really supporting that person so that they can function as a person in a reasonable manner. And in many respects, that's a very strong thing to think, because it means that we have the ability, often at our disposal, to really help people feel a lot better about themselves. You know, that it's not a magic pill that we need to give. It's often our kindness, our compassion, our love, our nurturing, our creativity, our happiness that will help somebody get through the day. And I think we underestimate that very often. So in person-centred services, you know, it's recognising that people with dementia have a really high risk of not being treated as full citizens. They have a high risk of being ignored, and they also have a high risk of being abused. You know, if you look at any study of abuse and neglect, people with dementia are the people that get it the most. So we have to recognise that that's an undercurrent always when we're providing services, that risk of abuse is high. And also that people with dementia have particular disabilities around communication, strong emotional responses, and a major need for continuity and to feel connected to others. So those two things are going on in tandem, and as the disease progresses, both those things become more acute. So if you've got somebody in early stage, this might not be such an acute thing. It's still there, but it's not so big. But as people go through moderate to more advanced dementias, these two factors become much more important. So particularly if we're thinking about care homes, where people are generally at the more advanced stages, those are two things that we need to bear in mind. And person-centred services respond to these needs in a proactive fashion. You know, we recognise they're there, and we do our best in order to support people, both who are at risk and also supporting those disabilities around communication. And particularly in terms of that continuity, it's dependent on us as carers, or particularly professional carers, to remember who this person is, what they love and what scares them. This is a guy who developed dementia in his 80s. He's probably one of the most famous people with dementia. Does anybody know who he is? No? Ronald Reagan, well done. Now, the young people in the room won't know who he is, but just to tell you, Ronald Reagan was President of the United States. He was before he became President of the United States, he was also a film star, you know, so we have a very sort of well-documented life history for Ronald Reagan. He's since passed away. But, you know, I used to think, crikey, if you had Ronnie Reagan in your care home, you'd have so much stuff on his life story. It'd be really easy to sort out, you know. You'd give him a nice big desk with a big red button and he'd be well happy and on the phone. But I remember hearing his son talk at a conference in the States about his dad. And in his dementia, the memories that he had was when he was a lifeguard in Illinois. So those, when he had that photo took, that's where he was a lot of the time in his mind. Those were the memories that he was calling on. And I think I show that just to make us aware that even often we know stuff about people, but it's knowing for that individual the things that, what they love, what scares them, what gets them up in the morning, what excites them. Because recalling the past plays to the person's strengths and it maintains relationships. You know, if you know how to be a lifeguard, you know, back then, and you get this guy talking to somebody that's a lifeguard now, you know, the conversation and the sparks will be there because they have stuff in common. Objects, activities, food, music, dance, all of those things that we can build into our activity programs will stimulate memories. And we need to be making sure that they're queuing in to the right memories for that person. We have opportunities to do that we often miss. This will maintain a sense of identity. It maintains a sense of who you are. And new people will understand the person with dementia much better if they know that life story. So even if the person doesn't know who Ronnie Reagan is, you know, if they know a bit about the history and the fact that they used to be quite an attractive guy, you know, that can help then form relationships with new staff, with younger staff, with staff from different cultures. And just for all of us to think about, you know, what's in our memory box? What's in our 20s and 30s? What would be on your iPod? What would be on your box of stuff? You know, what would be your food? You know, it's all of those. What are your treasures for the journey? Yeah. And I'd go home and write them all down now if I were you. Okay. So that stuff is still very new. And in my time working in dementia care, again, 30 years, it wasn't Victorian era, but when certainly the first 10 years of my professional life as a psychologist, the narrative was that dementia was the death that left the body behind. And as long as we kept it clean and dry and quiet, actually that would be the best thing to do. And that's a huge change that we've had over a relatively short period of time. We now talk about living well with dementia. And I think sometimes we forget about how quickly that sort of narrative has changed. And I think that helps in part when you think about it from an historical point of view as to why we're not better at dementia care yet. As Jason said, you know, a lot of the work around this sort of thinking around person-centred approaches, began with the late Professor Tom Kitwood, and that was only at the end of the 1980s, beginning of the 90s, that he started writing about person-centred dementia care. And the book, Dementia Reconsidered, The Person Comes First, was published in 1997. And he gave us some really important ways of thinking about the experience of dementia. And for those of you that haven't read this book, I'd still recommend it. I think there's if we did everything it said in that book, we'd be fine. You know, we have that sort of knowledge, but it's putting it into practice that's the problem. And the work that I've been doing has been trying to translate some of the very theoretical work that Tom started around this VIP's definition of person-centred care. And this is now in our NICE-SCIE Guidelines in the UK that's the blueprint by which we deliver health and social care. And enshrined in that in 2006 is this definition in the Dementia Guidelines on person-centred care. Person-centred care values and promotes the rights of the person. So it recognises that huge risk stuff there is around abuse and neglect in dementia, and says we very actively have to value that person's life regardless of age or cognitive ability. Person-centred care provides individualised care according to needs. Everybody reacts differently to their dementia. Everybody has a different brain to begin with. You know, everybody has a different life story. So it's about recognising that the individuals we're caring for come into our care with huge strengths, huge life histories and abilities, but also weaknesses and vulnerabilities. They're all different. Person-centred care tries to understand care from the perspective of the person living with dementia. There's an altered reality going on here. And if we can try and understand what the reality of the person is that we're caring for, that we recognise when Ronnie Reagan wrestles somebody to the ground, he's actually trying to rescue them from the waves that he perceives are coming up from the carpet. You know, we understand what to do better than if we just think, oh, that's aggression or whatever. So it's trying to understand things from the perspective of the person with dementia. And it's providing that socially supportive environment that enables the person to remain in relationship with others. It makes it easy for people to connect rather than hard. So valuing, individualised, perspective, socially confident. And, you know, we've used this framework both as, we can use it as guiding principles for our own actions. Do my actions show that I respect, value and honour this person? Am I treating this person as a unique individual? Am I making a serious attempt to see my actions from the perspective of the person that I'm trying to help? How might my actions be being interpreted? And do my actions help this person feel socially confident and that they're not alone? And you can put those principles into practice, whether you're giving somebody a shower, whether you're helping them go to the loo, whether you're running a life story group, whether you're doing a music session, whether you're giving somebody an injection. You know, they're guiding principles. It's not about the thing that you're doing, it's about how you do it. That's what makes the difference between person-centred care and non-person-centred care. And we've also then looked at that method, and we've been working with it now for around 10 years to look at it across a care organisation. To say if we're providing care providers, if we're being a care provider that values people, that treats people as individuals, that looks at the perspective of the person receiving services and supports their social and psychological needs, there are certain things that we would want to see in place, and this is the VIP's framework. I'm not going to go through this because this is a big lecture in its own right, and I want to get onto the choice stuff. There's nothing in here that is rocket science. This is stuff you know. But what we often fail to do, I think, is to recognise that we have different leadership roles within making sure these things get put into practice. There are things that our top team needs to do, the senior team, the directors, the boss. That's about human resources, training, quality assurance, service environments, the big stuff, the big setting conditions. There's stuff that your clinical leads need to put in place. You know, all of the things under individualised care often have a process attached to them, and somebody needs to work out that process and how it gets done on a day-to-day basis. Your shift leaders will often be the people who are responsible for ensuring that we've got skilled communication, that we're sensible about risk and rights, that we look after people's physical health needs, that we see challenging behaviours as communications. You know, it's actually a real pivotal role for your shift leaders. And then ensuring our social environment is good. Those are the stuff that everybody has to do. Include people, respect, meet people with warmth rather than coldness, validate emotions, not leave people shouting out in despair. You know. So, as I said, I'm not going to do a lot about this. If you're interested and you don't know about it, there's a free website, CareFit for VIPs. There's no adverts, I promise you. Nothing that burns away your fat or reduces your wrinkles or anything like that. You do have to register, but once you're registered, you're in, and you've got the whole thing. There's a version for care homes, there's one for domiciliary care, care at home, and one for daycare. And what you'll find in the toolkit is those 24 indicators, a way of reflecting how good or not good you are at each of them, but more importantly, a great searchable toolkit of resources to help you get better at stuff that you're not doing so well. And we've certainly been having discussions. It's a British website. We do quote a lot of Australian resources, and we've certainly been having discussions with Alzheimer's WA about making sure that the great resources that you have here get put onto this one. So, I mean, it's very accessible for an Australian community. Okay, just want to think through some of the issues around getting things into practice. How many people in the room would expect that if you had a child in hospital, that as a parent you would be able to visit that child? Anybody not think they shouldn't visit their child? Anybody think that parents should be banned from visiting children? Might have a few nurses who do children's wards who think this, but, you know. Well, it didn't always used to be that way. You know, John Bowlby was the first person in the 1940s who wrote a theoretical paper suggesting that infants needed a continuous parenting figure, and in those days it was a mother figure, in order to be able to feel safe and to grow up to have good relationships with others. Before that, the standard position was that really, as long as children were cared for, as long as they were clean, quiet and safe, that actually it didn't matter who delivered that care. You know, so that was in 1940. And in 1950, following Bowlby's researchers doing lots of observation studies on children's wards and witnessing the distress that there was in children who had been separated from their mothers, the World Health Organization endorsed this position. And one of the direct effects that had was to suggest that children should not be separated from their parents when they were unwell and in hospital. But that sort of radical theory shift takes a long time to become standard practice. And I was reflecting on some of the issues in my own family. And in 1949, my brother, who was 3, and I'd just like to say my brother is a lot older than I am, for those of you who are wondering, a lot older. He was 3 in 1949, so this is 9 years after Bowlby has written all this, and it's all in the, it's all in the medical press, and people are debating it. He spent 5 weeks in hospital. He had a mastoid on his ear, so he had an operation on his head, and my mum was not allowed to visit him. She says, for her, she can remember standing at the door of the hospital ward, seeing her 3-year-old stand up in his cot, crying out for his mummy, to be told that it would upset baby further if she went and hugged him, and she was not allowed to go in and see him. 5 weeks. My brother doesn't consciously remember much of that, but I have to say he's pretty needy when he's poorly, And that, it was only 5 weeks. It wasn't like 5 years. He wasn't that poorly. I do wonder, some of the people that we see in care who are very, very needy when they're left alone, I wonder about some of that early hospitalisations, because this is that generation, that would have had that separation from parents. Okay, 1967, you can now tell how old I am. I'm aged 8, so this is 17 years after the World Health Organisation declaration. I had my tonsils out, like many people of my generation. I was in hospital for 3 days. My mum came to see me, but she only came at visiting time, which was an hour a night. She never came down to theatre with me. She wasn't there when they gave me the big injection, So even 17 years later, in a reasonable hospital, she's still on restricted visiting. 1995, I had my baby. And when he was 5 weeks old, he had pyloric stenosis and had to spend 5 days in hospital. It was a very tiny baby, and it was a regional unit that he had to go to have the operation. There was no facilities for me as a mother. I had to sleep on the floor next to his cot because I knew my Bowlby, and I certainly wasn't going to let him go alone. But the encouragement was, you're exhausted, go home. He won't know. No, he will. So no, still 1995. 2005, same boy. When he's 10, he had his appendix out, and now we're in Worcester, which is lovely. And I had a bed next to him and a family sitting room by then. He didn't actually want me to stay. I was embarrassing, but I was going to stay. So I just illustrate that was a radical shift. What Bowlby was talking about was as radical, I think, as what Tom Kitwood has been talking about. 1992, we had the first theoretical paper towards a theory of personhood in dementia care. 2006, in the UK, we had that NICE-SCIE Guidelines, so it's in policy. So we apply the same maths. We should have institutionalised, person-centred care for people with dementia by 2057. So let's try and do it a bit quicker, eh? We have got the internet now, so we might be able to get motoring a bit quicker with it. But that's the time scale we're talking about. We've known that babies and children need parents in hospital, but it's taken us still, in some communities, a long time to get there. And in 2014, I think we're bumping along. There are certainly more good care homes than there used to be. The research we've done, I would say around 20% of homes are great. And if you've got a great care home, it's a joyous place to be. It's really good, and you know it, and they don't have staff turnover problems, and it's a beautiful place for your families and for the people that work there. I'd say, again, from our research, there's around 20% that as soon as you walk in, you think, oh my God, this is bad. where you feel unsafe, where things are wild, you know. And certainly, you know, we need to be addressing the far end of very poor care homes. But I'd say the other 60% are all right. They're mediocre. They're bumping along. You know, and they're the group, really, that we need to be shifting up into the good. Because with a bit of extra work, they could be great, you know. Unfortunately, with a bit of bad luck, they become bad, you know. And I think many care homes, at the bottom of the mediocre, they're held together by a few good care staff, or a manager and a couple of good care staff. And if one of those leaves, or they get spread too thinly, the culture of care changes very quickly, you know, because it's just held together, not in a proper way, but by some great people. If your quality of care then deteriorates and problems come to light, if they're not dealt with, it slides and the home starts to get a bad reputation. It then becomes difficult to recruit to, it may get sold on, it becomes very unstable, and it becomes a high stress environment for both staff and for your residents. And, you know, that's home to 60 plus, possibly, residents for whom instability and high stress is really toxic. So your level of difficult behaviours goes up, distress goes up, untoward incidences go up, and you get that downward spiral occurring very quickly. And in those situations, you need a very strong management and nurture to turn that home around, you know. And I think collectively as an industry, that's one of our big challenges, how we turn around these homes that are going into downward spiral. Okay, I'm going to go on to the choice project now, because if I don't, I shall not get to talk about it, and I do want to talk about it. This is the Cultures of Care project, which was a joint effort between 4 different universities and funded by the Department of Health and Comic Relief. And I have to tell you that my views are not the Department of Health or Comic Relief. I have to say that when I've put my disclaimer up, but there's a disclaimer. We were interested to study care home culture in recognition that care homes that have similar resources and demands can provide vastly different experiences of care to residents. So we think about the good, the bad and the mediocre. Actually, you could have 3 care homes owned by the same provider that were in all of those categories. You know, it's not really about the staffing ratio or the size of the home or whatever. There's something that we often talk about, that care culture, that makes the difference. And what we tried to do in this study was to empirically examine the relationship between care home culture and the experience of care for residents. So organisational culture are the values, the assumptions, the norms of behaviour that influence how members of an organisation behave and interact. It's rarely the stuff that's written down in the staff handbook or in the brochure, you know. It's there are formal rules, but it's usually the unofficial practices. It's the way we do things round here. It's what you learn, how things operate in a new work environment. And they're often at quite a subconscious level. The method that we used was we did 11 in-depth care home case studies. And when I say in-depth, our research was in there for 3 months per study. The care homes we chose ranged in size, age, location, registration and owning organisation. We started that 3-month care home, the 3-month case study in each case, with detailed observations of care as experienced by people with advanced dementia and complex needs. So we were going really in. The first thing we sort of got used to was what life was like in that home for the most vulnerable resident. And that's quite different to a lot of case studies, which often talk to the most able residents. So they do interviews, you know. So we were really determined to look at what this means for the people that are most vulnerable. And then the case study developed further observations and interviews with other residents, with staff, with management, with family, with visitors. And we used a particular methodology to try and identify those key practices and cultural elements that influence that care experience. Okay. So we looked at the 11 separately, and then we looked at across the 11 and tried to draw out the key themes. So, interesting methodology, which I won't go into. The paper's just about to be published in a journal called Ageing and Society. So those of you who are interested in methods can have a look at it, but you'll have to take it on trust that we did it well. Okay, positive care experience was facilitated by shared norms of practice, values and assumptions about care. So whoever you talked to and wherever you looked, there was a unity of what people thought they were there to do. We identified 7 elements of positive culture that were present through different practices in the home and that were acted out in different ways. Even in the very positive, you know, at the far end where you've got all 7 operating and it's beautiful care, poor care experiences still occurred, but they were unusual and infrequent and they were dealt with quickly. Yeah? So it's not saying that even in your good care environments you will come across complex situations, you'll come across poor practice, but it's how it's dealt with that makes the difference. These are human services. I suppose the other thing I would say is, given the nature of the research, the care homes had to agree to have us in their home for 3 months. So they had to feel fairly confident that this research team was not going to unearth anything really terrible. Yeah. So, you know, what we're looking at, by and large, are 11 homes who think they're pretty good, you know, and feel fairly confident and open. What we found on the other side of things was that positive care experience was impeded by lack of shared norms when people thought they were there for different purposes, when some of those elements were present but not all of them, and again the positive care experiences were dependent on individual staff. So again, even in the poorer performing homes, we saw some great care, but it wasn't carried through. And that's the answer, that's the magic 7. And I'll go through just going through each of those in turn. And I don't think you're going to be terribly surprised by any of them. But putting them together in that sort of diagram, I think it shows the interdependency of it. You know, there are beliefs and values that are there in that home that create a positive care culture. That care culture enables your norms and assumptions of care practice. So your beliefs mean that you do the good care. But also, the good care means you believe it more. You know, so there's like a virtuous circle that goes on, rather than that just being held in one individual member of staff. It's about, this is the way we do things around here, was embedded in the culture. So shared purpose. Everyone's got the same understanding of what person-centred care means in their home. They might not be able to give you the VIP's definition of person-centred care, but for example, one of the questions that we asked right at the beginning of our case study to all members of staff is, what advice would you give to a new member of staff starting in this home? And that varies. You know, some people say, never work a Mondays. You know, if you want time off, always ask John. You know, it was a completely open question about what advice you would give a new member of staff. All of them in the homes that were doing it well said words to the equivalent, get to know your residents. That makes your work great, you know. But if you don't know your residents, if you don't know what makes them tick, you'll have a miserable time. So that was a shared value. There was a sense of community between all involved in the care home. So from the oldest resident, the oldest, frailest resident, to the youngest member of staff, everybody felt that they belonged. And that was expressed in terms of the community. Residents were known throughout the home and they enjoyed everyday experiences. And there was lots of friendship-like relationships with and between residents. Visitors were welcomed, smiled, people knew them. The niece belonged there. She's not just an next of kin, she's a friend. You know, so there's that feeling of welcoming and friendship that permeated. Family. Staff were empowered to take responsibility for resident well-being through active management practice. And there's two bits to this one. So staff were both willing and able to make decisions that would improve resident well-being. So if we want to go into the garden because it's a nice sunny day, we can go into the garden because it's a nice sunny day. We haven't got to be worried that we're going to get told off because we've opened the windows or that Fred's not got the right shoes. You know, I'm empowered at my level to work in the interests of residents. But that the management was present. So there was something there about management being on top of if things weren't going well, it would be pointed out very quickly. This was the most unusual one, but my guesses won't feel so unusual for those of you that are engaged in care home work. What we found in the positive care cultures was that managers protected the daily work of staff from the impact of external factors such as inspection and regulation by absorbing it or translating it into resident-focused action. So I've put up an example of this one. Is the manager in this care home in a negative stance saying, making sure the T's are crossed and the I's are dotted, that's what the job's mostly about now. The amount of time that staff had to sit down and spend on care plans. And so in an observation, they're having to record how much food residents have eaten. So it has to go on a tick sheet to say how much they've eaten. And a carer asks about recording the dinner data for residents who haven't eaten yet. And another carer replies, just record a spoonful. The care plans are a care task here rather than the product, to the extent that we record something even when it hasn't been done. So it's about getting the form filled in rather than the food given. And this is whilst you've got a researcher in the room, remember, in a good care home. So, you know, it's in the better care homes, what you got was the manager translating that into the most important thing is that people get enough to eat and drink. You know, if we don't get the forms filled in, we'll fill them in afterwards. Make sure people get enough to eat and drink. I'll fill the care plan. I'll fill the forms in. I'll take responsibility for that. Openness changed the benefit of residents. So recognising that again, the benefit for the residents was the norm, and it was clear that we were going to help other people understand that. So a manager saying, you know, when we first had animals, I had a terrible time with the management committee because they said, we don't like animals, so why have you got them in? So we talked to them, we wrote it in the newsletter, the benefit that it gave to residents. We just kept talking about it and saying, you know, it's not going to go away, whether you think it's going to go, whether we're going to do it or not, we're going to do it. You know, so it's that doggedness of saying, this is what's good for my residents, I'm going to get it going. Benefit of change. And the care home environment used for the benefit of residents. So less about design, more about the use of space and environment. You know, bits of design. Bedrooms have memory boxes outside, although not all of them that are used. Betty's is covered in smudged finger marks. And there's a poem inside that talks about how much Betty likes to see her name, and she'll point to that and smile. It's about, this is personal to her. You know, it's got her fingerprints on it. It's not something that she can't touch. And that activity and engagement is integral to care work. it's not an added extra. It's not something we do when the activity coordinator comes in. And an activities coordinator here saying, I appreciate what the care staff have to do, it's tiring, and I feel that then to come on board with activities is quite hard for them. So at the moment I'm trying to support them as much as I can, giving them lists of ideas and things they can do, making sure that I've actually got the equipment or stuff that they can come and say, look, we want to do this today. So it's facilitating that activity rather than the doing of it. So it's all working together. So that's a choice project. Now, most of those things are common sense, but what we have very clearly in this research is empirical evidence that many of our common sense understandings actually make an impact most profoundly on those people with more advanced dementia. So that's what we were looking at primarily, you remember, was the experience of the most vulnerable. It also provides us with concrete examples of how homes have achieved a culture that provides those positive care experiences. And understanding to some extent how those different elements work together, but recognising that they all need to work together. So if we're about thinking about where we start in culture change, thinking about community, shared purpose, absorbing the tasks, seeing activity as part of everyday practice, it gives some very clear pointers. And I know Jason and I were discussing the sort of Eden alternative, Eden environments that you're doing, and I'd be really interested to think about how these key up with some of the Eden stuff. I suspect there's quite a strong crossover there. So, as I said, that one's coming out shortly. This is the, I'll just probably whiz fairly quickly through this one. This is another project that we've just finished, which fits into practice, focused intervention training and support. This is the one that looked at decreasing the antipsychotics in care homes. More acknowledgements. This was some original research, big cluster randomised controlled trial that took place in 2006. So we've known that this way of working has worked for quite some time. But what we've done in the most recent study is to try and find a way of putting that into practice across 100 care homes. So we've been interested to see about, this was a research study, and so had all the trappings of a research study. How do we get this in? What's a model for getting this into regular practice? The original study nicely showed that if you worked in this way, you decreased antipsychotics. I would suggest as well, we use very little physical restraint in the UK. We chemically cosh people instead. It's not that we don't use restraint, we just do it in a different way. But I suspect it would have similar impact if you were using physical restraints too. It's how we work with those behaviours that we find difficult in care. NICE report published by the Alzheimer Society. So that book is on the shelf of most care homes in the UK. Probably not looked at very much, but it's on the shelf. And it's also influenced, that research study influenced quite an important guideline on optimising treatments for behavioural and psychological symptoms in dementia. So what we did, the fits into practice model, was we employed 2 dementia practice development coaches. So these are very skilled people who were employed through our departments. They were part of my senior team. And they delivered a training and supervision programme to dementia care coaches across the 100 care homes. So these were people who were working in the care home, who were nominated by their manager to take on the role of becoming a dementia care coach. So it's like an internal specialist worker, a bit like a dementia champion role or the sorts of specialists that we're used to. And the dementia care coach had to implement their learning from the FITs in 1 or 2 care homes, supported by the dementia practice development coaches. But this was possibly a fairly more intensive level of training than we'd think about on most dementia champion type courses. So we were looking at 10 cohorts, so 10 training cohorts of dementia care coaches. They attended a 10-day programme over a 3-month period, and they met fortnightly in 2-day blocks. So it was quite an intensive training programme to get them to think about the effects of antipsychotics, how you analyse behaviour, how you get people off, what activities you do, what the safeguarding issues are, what the risks and rights are. So all of the good practice that we know around helping people with distress behaviour. So they had the training block over 3 months, meeting fortnightly in 2-day blocks, and then following the training, they had monthly supervision sessions again in their groups for a 6-month period. So this is pretty intensive stuff. And it worked. You know, what we found was we still achieved a 30% reduction in antipsychotic prescription, and actually our case study data showed that that's probably even greater than that. So it got people off the drugs. Significant improvements in quality of life for the residents. The coaches really valued the impact of their training, supervision and support, and in our case studies, the impact spread beyond the staff and the residents who were the initial focus. So this seemed to be doing something to really shift culture change within the homes that it was successful in. But successful implementation occurred when dedicated time and support was given to the dementia care coach. And time pressures were the main barrier to implementation. So again, we're back to this whole thing about this will work, but it has to be working within a home that will enable it to work. So just sending the staff on the course isn't going to change practice unless they're allowed to change practice. And lack of management support and poor communication was what hindered implementation. And out of the 100, we had 67 complete. So we had, a fair dropout of places that didn't complete the course. And this is free training. But we might think why that is. This is the Lady Forrester care home that I would say is in that top 20%. It's a good care home. It's a nice place. There's a good culture of care. And they look after people with some very complex needs. And this is Mrs. May Williams, who has a moderate dementia, vascular dementia. She'd had pneumonia and she'd spent 7 weeks in a hospital ward. And after 7 weeks, she was transferred to the Lady Forrester home with the very comprehensive care plan up there. All needs, no mobility, not eating. So essentially, she'd been sent to the Lady Forrester to end her days because she hadn't ended them on the hospital ward. And you can see 6 days after admission, she's looking a bit dishevelled, but she's up, sitting up, taking an interest in what the lady is showing her there. 1 month later, she's baking. This is a lady who's been a homemaker all her life. She can't no longer make a full course dinner or a big cake, but she certainly knows what to do with flapjack when you put it in her hands, even if she does have to wear the nice blue rubber gloves because of health and safety. This is a pleasant thing. This is something she feels happy doing. 6 weeks later, we have an Italian meal. She's certainly looking a bit fuller in the face now. She's had her hair done, and she looks like she's ready to eat. Tea and Teddy. Indian head massage. I doubt whether May had ever had an Indian head massage in her life, but this is something that is obviously a new experience that she's up for. Knitting, again, big knitter all her life. Can't knit a full jumper, but certainly knows what you do with wool and knitting needles, even if stitches get dropped, you know. But this is a very familiar thing for this lady to be engaged in. Other new experiences around, you know, sensory silk scarves, thinking about the sorts of things that you don't need to be intellectually on the ball for, but are really pleasant, nice experiences. And 3 months later, she's up dancing to music. And then we have our Mexican celebration. I think this was possibly during the World Cup, because I think they had the Italian and the Mexican World Football Cup. But, you know, if we think about no needs, no mobility, not eating, this is just good person-centred care. This is what cures. This is what rements people. This is what helps. This home just were taking pictures of their regular activities as a matter of course, and it wasn't until they sorted through the photos that they started to see the changes that had happened to May, you know. The staff in this home would have thought, that's just what we do. We haven't done anything particular. But for them, seeing the difference that their care had made is a huge boost. And that's the thing about, you know, that then reinforces that norm of care, which is get to know your residents. You know, so the more as managers and leaders we put back in that help staff see those sorts of things, the better. What's the most important equipment for a resident in a care home? It's the frontline care staff. Who maintains that valuable equipment? Who keeps it tip-top and fit for purpose? Shift leaders, managers and owners. You know, if we're looking for a priority, that's where we've got to put our priority, I think. And when I'm 84, I want my care home to pass the mum test and the daughter test, and the dad test and the son test. Now, the mum test is something that Andrea Sutcliffe, who is she's our Chief Inspector of Care Homes in the UK now, so boo hiss, usually when Andrea comes in the room. She's pretty down to earth though, and she says, you know, what I'm telling my inspectors is this place isn't fit for their mum, then it's not fit to operate as a care home. You know, so that's the mum test. You know, you can cut through the paperwork. Is it fit for your mum? And Professor Jill Manthorpe, who's a very clever gerontologist, when Andrea Sutcliffe said that, she said, well, that's all very well, Andrea, but I'd like to suggest it should also be fit for the daughter test. She said, would you be prepared for your daughter to have a career in that care home? And somebody who was really right on said, yes, and would you be prepared to have your son have a career in that care home? You know, and I think there is something there very true about the status of our work. We've got to, you know, it's about how we value those frontline staff. And if it's not seen as a valued career, then I would suggest actually our cultures of care will probably remain bumping along the bottom for a lot longer.
Lady right at the very back.
I just want to know if you'll be offering your dementia care coaching course here for us.
Well, I think that should be something to discuss. I think again, this will be published. You know, we're just writing up for publication. And it then becomes part of the evidence base for saying what really makes a difference to practice. And we know that this makes a difference. Certainly we're in discussion now with the Alzheimer Society in the UK to look at offering that as a course, you know. WA, yeah, you can.
I'd just say that we have got a submission into the Federal Health Department at the moment for funding for a residential care dementia champions programme. We have a dementia champions programme in hospitals. We have one in community care, which we launched this year. And we do have a submission into the federal government for a dementia champions programme into residential care. And a part of that is very much about the commitment of the organisation and about the support of senior staff to really support those champions to get in there and really make a difference. So keep your fingers crossed, everybody. We should know in about 2 or 3 months if we've been successful with that submission, and we'd love to work with you all if we are.
And it's a really important role, I think, in terms of raising the status. You know, what we found through the case studies was people who did that course may not have had, you know, a great time at school, they might not have had very many qualifications, but they were people who could really lead in their team. And it's the next step up for those care staff that we all work with, or our seniors, you know, who are our senior care team, who blossom in that area. So I think it is about, you know, it's about the daughter test, I think, that dementia specialist practitioner.
Quick question. In our first review, we got shown a video in one of our classes about a home that specialised with older people with dementia. And what the lady who founded it and came up with the stuff did, she refused any medication on a facility. So there was all of the residents and stuff weren't on any antipsychotic medication. And what she did instead to kind of counteract and stuff is she'd have different rooms to that would be similar to what they grew up with. I was just wondering on any particular research or your view on that, because I know there's a lot of debate and not very much evidence as to say whether antipsychotic medication is the best or isn't the best.
Yeah, I mean, we certainly know that antipsychotic medication has some very serious side effects for people living with dementia. You know, it causes, in the UK, we estimate that we have 1,800 people die a year from the side effects of antipsychotics who have dementia, from stroke, from falls. We also know that once people get put on antipsychotics, they're on it for a very long time. And so our guideline now is very clear that it should be reviewed after 12 weeks and you start reducing. And usually people reduce and you get them off it. For some people, a small dose of antipsychotics seems to keep them well, you know. So I think it's going back to our VIP stuff. It's about weighing up each individual case, rather than going the other way and thinking everybody should be on antipsychotics or nobody should be on antipsychotics. It's about really, I think, working with the individual. And in terms of specific environments, again, I think that has a logic. When we think through the timeline that I put through, you know, if you play 1940s music, people are more likely to engage than if you play, you know, 1990s music, you know, or having the radio tuned to a channel that's going to have more of that on. But there will be some people who are driven mad by that. You know, there might be some people who get very traumatised when they hear 1940s music because it takes them back to a place where they don't want to be. You know, so it's about, I think, recognising some of these things are very helpful and thinking about your environments and why you're doing it, but also then having an eye to individual difference. In terms of a palliative approach or... ensuring the best possible palliative care is available. Yeah, absolutely. Yeah, and you know, we have a lot within a palliative care approach, which is very person-centred, but certainly in the UK, we tend to think about palliative care for people with cancer rather than with dementia, and we've got some really good work going on now looking at best end-of-life care for people with dementia. You know, and it's trying to take the best from both worlds, really, isn't it? And also at the, you know, diagnosing earlier and being more aware of what people's end-of-life needs are. You know, if we think about what's in our treasure box, some of us would have very strong feelings about how, who, you know, all of those issues around our death, for example, and we find that very difficult to talk about generally.